Hey there, it's Hoang with Hand Therapy Secrets. Welcome to my show. I have today an amazing physical therapist and certified hand therapist. I don't know if you know, but physical therapists can become certified hand therapists too, and they are just as amazing as occupational therapists. So today I'm going to introduce to you Anne. If you haven't met her before, it's Anne Porretto-Loehrke. I hope I'm saying her name correctly. But I met her several years ago at a conference, and not only is she a practicing certified hand therapist, but she teaches in several different places. She teaches with the Academy of Orthopedic Medicine, IAOM USA, and she also has several courses on MedBridge. So I'm going to leave those links for you, but listen in. She's going to teach you some nerve stuff, and I always love the way she teaches. She says, or she explains things so easily to understand, so I really love that about her. So watch the whole thing. Not only will she teach you a few things that you could do right away, but you'll be able to find her courses if you go and look in the description below. Hey everybody, welcome to Hoang's show. Today I have Anne. She's an amazing clinician. She's a physical therapist, a certified hand therapist, and she travels the world to teach, right? I'm going to say the world because
I've done a couple courses in other places, sure.
Yes, but she goes everywhere to teach live classes. She's got online classes, and the way I met you, Anne, was actually I went to a Thoracic Outlet Syndrome course that you did for the American Society of Hand Therapists. Like, actually looked at that course and I was like, I want to take that. And that's how I ended up going to that conference. I actually ended up meeting a therapist here in South Florida who her and I became great friends because we were both going and doing that. But I really enjoyed your class. And you actually wrote a chapter in Rehab of the Hand that I think everyone should read. So you've done some amazing things. I'm really excited to have you on this show so you can share with everybody like everything that you do and share some real key tips for whoever's watching the show to be able to use right away, and then to be able to follow you and take more of your courses. So thank you so much for joining us.
Well, thank you. Thanks for having me.
So tell us a little bit about what you currently do right now.
Yep. So I work in a large hand center, and it's a smaller city in Wisconsin, but we see a lot of patients that come from all over. But I'm a co-manager of the clinic. I do some administrative work, but about 80% of my time is treating patients. And I practice full time. I've been a therapist now for 26 years, 20 of those years just in hand and upper extremity. And I see a lot of patients with more nerve entrapment, nerve compression syndromes, thoracic outlet, but I also see patients with trauma too.
Yeah.
I love making splints. It's fun. I'm a little artistic too, but I love being in the clinic, treating patients, and then being able to teach and look at updated research and help to integrate that, because I love helping clinicians to streamline their approach and looking at their patient from a systematic fashion, and not just like, okay, well, I learned this technique. I don't like to teach techniques. I like to teach kind of a thought process.
Yeah.
And I think that helps them to become more efficient of a clinician.
Yes.
And it's neat to see too how the literature has changed, and how we treat things 10 or 15 years ago is very different in some respects with what we do now. And that's what's exciting too, is to share that. What's new, what's up, and it's neat to see too how the literature has changed, and how we treat things 10 or 15 years ago is very different in some respects with what we do now. And that's what's exciting too, is to share that, what's new, what's up and coming, and what are things that we can change to help our patients to get our best outcomes.
Yeah, no, that's awesome. So that's how I pretty much got started in deciding, okay, I want to do private practice. And now I've been able to grow in the last 7 years essentially into 2 therapists, coming on. And one of the biggest things is people who apply for jobs at my place, at your place, at different places, are going there and saying, I don't have the skills.
I want to be a hand therapist, but I don't have anything. Yeah.
I want to be a hand therapist, but I haven't taken any classes. I don't know what I'm doing. I don't know how to splint. I don't know how to do wound care. I don't know how to touch people.
Right.
It's like, you're like, holy crap, like to train someone. And I've trained people, and the thing is like, just because you train somebody doesn't mean they're going to stay with you.
Right. Right.
Why only give one or two people the opportunity?
Right.
When I started my business and I had students, it was a little easy because you're teaching them. But then when you have to repeat yourself over and over, I'm like, wait a second.
Why don't we record this?
So I record everything.
Yeah.
If you see some of my earlier stuff, like I wasn't like, oh my God, the camera, I would, and then turn the camera on and be like, and now it's like, oh, whatever, just turn it on. Just
Right. Yeah.
So I started recording a lot of stuff, and when I hired one of my first full-time therapists, I have to show everything, like every little thing. And employers get mad when they have to repeat themselves, but you can't just learn from just one time.
No, true.
Very true. To learn from just one time. And so that was my thing, like, let me make this video. So I'm going to teach you once, and I'll go over stuff a few times if you really need. But in the meantime, watch these videos so you can continue to learn. So we can move on to more things. Because hand therapy is huge.
It is. It is.
You're talking about fingers. I am about to go into extensor tendon, and that alone, like reviewing chapter 38, it takes multiple videos.
I mean, just the anatomy and understanding the extensor mechanism itself it's really hard. It's really, it is.
It's really hard. I read that chapter 15 years ago, and now I'm reading it again, and I'm like, okay, so how do I break it down in a different, so I just have the opportunity now to read it a little differently.
Right. Well, because you have the clinical relevance piece, and it makes it that much more that you can add. So when you're teaching it to somebody, you're not just like, okay, you have a trifurcation of the extensor, you can say, hey, when someone has an injury here, you're going to see this, and this is why this is important. And
so I want to build something like you had for that class that I took of yours back in, like, I don't know. But
I brought it with me.
Yes.
The giant scapula.
Yes, I brought it. A giant scapula. But not only do you have a giant scapula, but you have the tubes. You have the tubes, and you would pull stuff.
Right. Yes.
So it's so funny because think about that. Like, you think I'm kidding, but I always think about, like, I need some props.
Yeah.
I need some.
I mean, I love making splints, but this is even more fun to make.
Oh my God. I remember saying that you made that. I'm like, I need like paper mache, a PIP joint, and I just tie some lateral bands to it.
Because I am totally a visual learner. So that's why I decided this was the way to go. Because when I did this, I was like, I totally get it. And I see so many people that are like, because therapists are visual learners, and they're like, oh,
we're tactile people too.
Right, you want to feel it, touch. You want to see that costoclavicular space, You want to
I can't even say that word. I just like point here.
And too, I love using this like to understand the scapulohumeral rhythm and what when I put on the Velcro straps for the muscles, how it moves, because that whole piece, even therapists practicing 20 years still can't grasp that.
Yes.
So I think it's
use my hands.
Right.
I use my hands
to be like, hey.
When I teach, I draw. So I literally draw blocks. Like, you should have seen like one of my videos. Like, sometimes your drawings kind of might come out like a little phallic. I'm like, whoa, hold on. Like, let me erase some pieces here. That does not look right. I draw two-dimensional, like,
Right.
I teach off of a whiteboard.
Oh, okay.
I don't believe in PowerPoints.
Okay. Well,
for me and for the specific program that I have, I don't believe in PowerPoints. I need people to like
be focused and got it.
Focus, and so one day I'll have PowerPoints, but not right now.
So do you do it on a weekly basis, or how did you do your program?
Yeah. So my mentorship program, so I have two programs that are weekly calls with me. So the hand therapy mentorship program is a weekly call. So you just meet every Thursday at 7 p.m.
Mm-hmm.
I lecture, so I structure it. So I lecture a little bit, but then it's all about questions.
Gotcha.
So what's great about it is that who are seeing patients in the clinic have questions about, well, I have this particular case, I have this particular case, and they just don't have anyone who's gonna really take the time to explain stuff. And so that's why they can come onto my program, and I'll either one, make a video if they send their questions in prior, they just get access to me so I can explain certain things, and then I can help them. So when they actually see the patient, they know what they're doing. They're gonna feel more confident, right? And then we can dive into more of it on Thursday. So, so if they get a patient, they're like, I'm seeing this patient on Wednesday and I need help. I help them. I help by email or create a video that if someone had a question, so it was very useful. So then what I did was I have a private Facebook group just for my students. And I go in there and I was like, okay, this great question. Let me help you think through the problem. Anytime that anyone has that kind of particular problem, you can think through it. Why would I make this plan? Why would I cover this joint versus that joint? And what am I allowed to do? Right? So it's not just like, let me teach you one thing. Let me teach you how to
teach them how to problem solve. And that's huge.
And then make a decision. Problem solving, decision maker.
Right.
Solve the problem. Get your patients to come back to you. Because when patients come back to us, we have jobs, right? When patients come in, we have jobs. We have a career to build, you know, that type of thing. If there's other things that can wait, then we wait for the Thursday call.
Gotcha.
We get on the Thursday call, we get structured. So last month we did shoulder. Actually, this week is the last week of shoulders. Then we move into flexor tendons. Flexor tendons. And then after flexor tendons, so the topics for the month are structured. I teach on that. I showcase certain things, and then it's open to questions. So then it's open to questions, and then my hand exam prep group is a 12-week structured learning to prepare for the exam.
Gotcha.
So not everyone who's, you know, works in hand therapy needs to like dive into the rehab of the hand and read it. But if you're studying for the exam, you need to read it.
Right.
Like, oh, I study off the questions, but there's so much information in the book and so much about picking out the right info. And it's important to have you on the show because you wrote a chapter in there. You did. I think when I bought the new volume, I was like, oh, I took her class. I knew her. Like, I know you, Anne. We're LinkedIn friends.
Right.
So that must mean we know each other.
Right. I have people come up to me at conferences. You look so familiar. I know you're in rehab of the hand. I'm like, oh no. Because when we did the chapter, it was like in 2008. They said they were gonna have a medical illustrator. They said, oh, just, you know, do some videos and still shots. We'll have a medical illustrator do this. And then they're like, oh, your photos look good. We're just gonna keep that. I'm like, oh my gosh.
You're like, wait, did I get my hair?
Well, it was before my daughter came in 2010, so I looked a little thinner. So I guess I'll just leave it. So and actually that was a really fun experience doing the chapter for rehab of the hand. One of my coworkers did it with me, and we had a blast. We really enjoyed it. We did.
You get invited, and who do you? A lot of people, because every time I talk, you're like, oh, and this person that I know, and this person.
I think, well, a couple things. Like, I signed up in 2006. They had the thing for item writers for the Hand Therapy Certification Commission. So I'm like, I love writing questions. I would love to do that. So I applied and I got it. And it was in Napa Valley that year. And they only bring in item writers every 4 years. So I met Mo Herman, the president of ASHT. She was an item writer. Mike Crecho was an item writer. All these people that now I'm friends with for years were all item writers at this little meeting. It was a weekend or 3-day meeting in Napa Valley that we learned how to write questions for the CHT exam. And then from there, everyone was responsible for writing, I think it was 40 questions. My mentor, Dorit, I don't know if you remember Dorit, Erin, she's in Houston, but she was a former ASHT president. She was my mentor.
I recognize the name.
Yeah, so she was my mentor for that group, and it was just a great way to just get started meeting people through Like, you know, just because, you know, I live in Wisconsin. Yes, there are lots of dairy farms. The city I live in is like 70,000 people, but I work at a really large hand center that sees people from all over the place. So it's kind of nice. You get to see a variety of things, a lot of trauma, a lot of just weird stuff that doesn't get better at other places we get to see. So that's kind of nice. At that meeting then I met everybody, and then I was also at that point in time, was doing my DPT at Drexel. It used to be MCP Hahnemann, and that was Jane Fedorzik's. She had a certificate program for hand and upper extremity, but if you did your DPT, you could take some of those courses to have an emphasis in it. And I was like, well, I want to do that, because I had started at a university in Milwaukee that was just a general, and I remember doing a lecture for my kinesiology class on the PIP joint and the amazing volar plate and all these cool things about that. And I remember one of the students who was also PT in the class, and she's like, who really cares about that? And I was like, I'm in the wrong place. So I transferred to Drexel at MCP Hahnemann, and I was like like-minded. It was wonderful. Like I got it. It was at that time I had to fly to Philly like 3 times per class, but it was so worth it because I got a chance. Well, like Terry Skirvin came into lecture. Jane lectured. Dave Ebaugh, who is a great, I mean, so I got a chance to meet more people in Philly. And then after that, I got invited to the Philly Hand Conference. And I did that for 4 years until my husband's like, time out, because I was doing all this other stuff, and I get it. Probably like the last Philly conference, it was the 2014. So my daughter was 4, and my husband came down with the flu all like just before I was supposed to leave, and I was like, I don't know what I'm gonna do. And that was and so I would love to go back sometime and present there. It's just with working full time, I work like 45 hours a week, and I teach courses. It's just But anyway, so that's why I got a chance to meet all these people, and it was great. It was really great.
Really awesome.
And then just teaching courses across the country, you just get to know people, because a lot of times so the Hand and Upper Extremity Track course that I helped develop, there's 6 of them. And usually people if they take one, they end up, a lot of them taking all 6. So you get to see them in different parts of the country, and you get to develop a relationship. So that's always really fun. You know, it's like I have some friends in Arizona, some in New York, some in, you know, Washington State, and that's really, really fun. So I think that's my favorite part.
So tell us more about where you teach, or where, like that, about that upper extremity track. I think after I took your TOS, Thoracic Outlet Syndrome course at the hand therapy conference, at the big therapy conference, I did look on that in that company to keep learning. And your live classes I'm on the East Coast and you stay on the West Coast. I guess at the point of time when I met you, your husband was like, you woman, you staying next to like this side of the world.
Well, the East Coast, honestly, we haven't had a whole lot of courses. Now we're getting more, because Mirka, she and I are the lead teacher, she lives in Connecticut now. So we're starting to get more there, which is great.
Maybe I should talk to her too.
Yes. She's getting her PhD right now in Montreal in biomechanics, and Thumb CMC is all her research. So she's busy, but she's amazing. Yeah. But we teach all over any city, you know, so we've done a lot, like in Texas, we've done we did a lot in California, but not the last several years. Like Nashville's a big one. We get a lot of people there. Atlanta, we've had some. So, you know, it kind of just varies. But
and those, you going to these courses relies on the facility bringing the course to their facility, right? So they bring you to their facility.
Right.
And who sells the course? Like that company or the?
IAOM, International Academy of Orthopedic Medicine, sponsors the course. So they do all the registration. They take care of the manuals. We still have manuals. I'm pretty strict on that. I think we need a manual and I'm into PowerPoint, but there's 2 PowerPoints per page so that you can really see the slides. So so a facility just offers, and then they set up the registrations, and then usually there's 2 of us that teach together. It's good to have like 2 perspectives. Crux of it is based on the work of Dr. James Syriacs, who was a physiatrist who gave therapy a good systematic approach to how to evaluate your patient. So we follow that, and then the manual techniques that we use, again, we do a lot of lab. We do surface anatomy. We draw out everything. Like for the hand, we draw out the extensor mechanism.
I do that all the time.
Us, understand, because I'm a very visual learner. So we go through then, and all of the hands-on techniques, we practice them and we lead them. It's not just, oh, here's a bunch of techniques. It's like, okay, let's lead you through the story. Where do we begin? What is the most important pieces, and how we evaluate, how do we determine the pain generator? And then what are we going to do to treat that? And then we go through with some of the manual techniques. So I feel like the courses, even though they're manual therapy courses, the most important part is the clinical problem solving, that systematic approach. Whether you do the manual therapy or not, there are oodles of ways to do manual therapy. You can use tools, you can use your hands. That's not the important part. The important part is knowing, I know the problem, and knowing something, if it's a problem you can do something about, is just as important as knowing if it's something that you shouldn't, that's like, no, this is out of my scope. Like you have a positive scaphoid shift, you have a significant instability, they're likely not going to get better with conservative. They need to see a surgeon. So that's the type of thing we try to teach people, how to be an efficient problem solver. And it will then, because especially in today's clinical environment, people have high deductibles, they have limited visits. I don't want to mess around for 6 visits thinking I can help them and decide, oh, really, maybe this is not something that that is going to be a therapy thing that's going to help them. So that's really what we try to teach is, let's get to the root of the problem. The patient history is so critical. Okay, there's certain things you're going to see with this age group. There's certain things you're going to see if they're female versus male. And all those things come together so that I already have an idea in my head of the possibilities of what this could be. And then I do my exam, and then my special tests confirm that.
Do you know that is the hardest part, is that way of thinking?
It is.
That's the hardest part, is that for a lot of people, because once you learn something, like most people are just looking to learn something, whether it be the tools or the tape or the manual or the exercise, got to do a couple of things, right, before they can actually get to the full, because that thought process that you just went over, like sometimes that's the hardest part to teach. Hardest part to teach.
Well, that's what makes an expert clinician, right? Is being able to synthesize the information. These are my possibilities. This is my exam. I think it could be this, this, or this. Here's my special test to confirm. Right?
Right.
But it is. It's the hardest. And it's the hardest.
Interpret the results.
Right. And I don't think schools necessarily teach in that way, you know? So they get out of school, they have, like for the shoulder, let's take the shoulder for example. So you get all these special tests, okay? What do you do with that? Where you see a patient, it's like, well, where do I start? And you find out you don't need, of all the special tests, maybe you're going to need 2 or 3, but how you get to that point, no one teaches you what you need to look at to figure out how to narrow down to what the special test you need. And I think that's part of the issue.
But I also think that sometimes people just use that for a way of getting started. So I use that as a way of getting started, because then when you're ready, or when you've gotten a few things, practice under your belt in a way, then you go and you do dive into the why.
Right.
Or you get to the how. So you get to the why, the what, and the how. So the why part comes from, like, that's why people should read the Rehab for the Hand, right? So essentially what I teach in the exam prep program, because in order to answer those questions correctly, you do have to know all 10 of those special, like for example, 10 of special tests, right? But when you get the scenarios in the test, just like you would get a scenario of someone coming into your clinic, you have to be like their age, their sex, you know, what do they want? Okay, so the symptoms. Then out of those 10 tests, which one's the best one to do, right? So then it's not so much about which technique you use. Do you use modalities? you now know the story.
Mm-hmm.
And you can pick the best, and you become the decision maker. Like I say that all the time. You have to make a decision. There's 4 choices on the exam. I mean, obviously they're just giving you a scenario, but when you learn how to think like that, you
It's much easier.
Thought process, when you apply it when a patient comes in and they're like, well, I didn't fall, I didn't do anything, I woke up like this. I woke up like this, you know?
Okay, what? Yeah, right.
Yeah, and then you have to go, then you've got these like little indexes in your brain. Okay, age, sex, injury, onset, you know, type of stuff. How do you ask to dive in a little bit more? Where's the pain? When does it hurt? You know, how does it hurt? And then you can say, okay, well, based on these things, you know, then you can dive into a little bit more extra steps.
Right. Yeah, absolutely.
That's pretty much what we do. We're critical thinkers and decision makers.
Right.
In therapy.
But that's a hard skill sometimes to teach. Even, you know, it's interesting, even therapists that are practicing a very long time, and you introduce them to that and they like it, they're like, oh, this is really, it makes you think. It's not just, oh, here's your anatomy, it's like, it makes you think. And I think especially hand therapists, the protocols are very much guidelines. They are not like, okay. And I think you have to be able to think beyond and problem solve to make a decision then on when it is appropriate to do this, or maybe we need to slow down and not just follow it's at 6 weeks, we need to do this with the protocol. Getting out of the protocol based mindset and more into a clinical problem solving. That's our guideline. And we've got we've got structures we need to protect, but then we also, I think people think that doing no harm is not doing enough, but sometimes doing harm is not doing enough, right? I mean, think about with a tendon. If a tendon's getting stuck and you decide that you don't want to go to the next step of maybe doing a tenodesis, you are harming that patient. So it's not just, oh, I'm not going to do anything because I'm not sure that I want to be safe. Sometimes we're not safe because we don't do enough.
But, girl, I could talk about that all day. We can tie that to insurance and insurance-based and
right.
True. Stuff too, because sometimes we have certain assumptions because of that, and we don't even like. So I do a certain amount of insurance, but the rest I'm cash-based. So we try to go in there without any assumptions. And that's hard.
It is.
You're supposed to go in there without assumptions, because there are some people, and I've had experience myself where my insurance limited me to 20 visits. My physical therapist discharged me after seeing me for 5 visits because she wanted me to save my visits. Save them for what? It's the beginning of my career, and I kind of was like, well, if they say I can do it myself, I guess I could do it myself. But if I could do it myself, I'd stop eating and I have a 6-pack by now, right? But I don't. We all need a certain amount of help and accountability, and that's why a lot of times people come to us.
Right.
As therapists, we help them. We hold them accountable. We show them how to progress. It's a huge part of what we do. We can't get tired of saying the same things over and over.
Right. That's very true.
You know?
That's very true.
But I love the fact that you've been able to do so much. You practice, you teach, you've written questions for the exam. Done so much, and you still can. You've written in like the most important book,
the Bible, right?
You know, it's awesome. You know, it's awesome.
Well, when you write a chapter, what you get as a thank you is you get the rehab of the hand, and one day this big box arrives, and you're like, oh, and I just had that joy 2 months ago because the new edition came out. And it's interesting to know, you know, you think about stuff you read in books that is kind of outdated. Like the update that we did for the chapter, I'm trying to think of when it was. So the original, we had to get our stuff in by 2008. It wasn't until 2012 that it was published. So this last one that just came out, it was 2.5 years ago that we had to have everything in. 2.5 years. Yes. So because it was Halloween, I remember, and I was trying to finish the chapter, and my daughter wanted to go trick-or-treating, and I'm like, I just need to read it over one more time and then send it. But it was like, I think it was 3 years ago, and it just came out. So I got this box in the mail from Elsevier. I'm like, what's this? And I opened it up and like, Oh, there it was.
Like, what?
Well, and I have to just keep it. Oh, I keep it actually where I spend a lot of my time at home, which is in the laundry room doing laundry. So I open it and I look as I'm folding clothes, and I just peruse and I touch the pages. It's fun.
You're so funny. That's awesome.
But that's what you get for doing it, is you get the rehab the hand, and it's great because you look at it's like, wow, everything's like so glossy and beautiful, and there's so much good information in that book.
It really is. Great. I do encourage a lot of people to read that.
I still love reading it. I still love going through, like, reviewing where the scar is and what the limits are. I mean, it's good stuff. It's good
because you're special.
Yeah, I know. I'm a hand therapist.
Yeah.
Yes, I am.
Not that many people go. They're like, oh my, it's so dry. But let's be honest. Like, there's a lot of parts of it.
You need to get through those first several chapters. After that, it gets better. I think it's gotten a lot better from like 2 editions ago. When I studied for it, it was like, oh. But I think it's
which edition I studied. But I studied initially started off with the red books.
Yes. Okay.
Yeah, because they were the ones that were there. And
then the yellow came out. The yellow one.
And then I think I studied off of those. I think I studied off the yellow ones, because
the yellow ones I think were the ones I did.
The red ones, and I was like,
red ones were really old. Yes.
Yeah, those are really old, but they were the ones where the hospital had. And then when I went to study for, I was like, I need new ones. New ones. And then we'd gotten the blue one. Yeah. I've got the 6th edition. I'm probably going to buy the 7th one just to have.
Yeah.
As doing the hand exam prep program, I want to kind of show the difference. But
no, it's good. I won't say a word. I've got my laptop stacked up on the 6th edition right now.
Yeah.
All about,
yes, make sure, right? From underneath you see our notes.
I want to, it's got to be from above and not below, because that would be bad. Yeah. Yep. So, but really, I love reading research articles. I love learning new things, especially too, like with the nerve literature. It's really interesting to see like what's new with nerve gliding and what are some different, more novel ways to do it. And it's cool to catch up on all those things.
Yeah, we get a lot of nervy people here. I'd love to go into what you can share, because people are going to watch this. I've thousands of OTs watching from all around the world. I've got, people reach out to me all the time. And so I really want to share with them, anyone who's watching, something they could do right away.
Okay.
Something that you think would help their understanding and then doing, right? So just like a quickie, but
all right. Okay.
As much as you want to share.
So, I think it's good. We can talk a little bit about thoracic outlet, because I think that whole plays a role of everything downstream. And when you look at the double crush literature, we see in some of the studies that about 25% of people with distal nerve entrapments have a proximal component, being thoracic outlet or cervical radiculopathy. Some of the more recent studies looking at more the thoracic outlet piece, especially related to ulnar nerve issues. So a couple of things. Number one, I'm suspicious if my patient comes in with bilateral somethings. It's not always the neck. It's not always.
So bilateral, think neck.
Bilateral, it can be the neck, but sometimes it's here too. And I think it's important that, especially if it's more ulnar nerve, be more suspicious of thoracic outlet. So
would you say that same thing for a median?
No. And the reason is because the brachial plexus, so
here she comes with the props. I love it.
The props, yes. So the brachial plexus, so you think about the lower trunk is made up of C8T1, goes into becoming the ulnar nerve. So here's my giant scapula. I love him. He's great.
I couldn't wait for you to bring it out. Yeah.
He's been with me. I made him maybe about 18 years ago, and he's getting a little fragile, but we've had some repair work on the AC joint, but still looking good.
Thank God you're a therapist.
Yeah. So here is right here the clavicle, and here's the first rib right here.
Yeah.
So when we think about the passageways where the nerves come from your neck down into your arm, we have the scalene triangle, we have the anteromiddle scalene attaching to the first rib. So we have the brachial plexus going between the anteromiddle scalene, going over the first rib, underneath the clavicle here, okay? And then underneath, here's coracoid process, underneath the pec minor, coming down.
Yes.
Now, what happens when you look at the first rib, the lower portion of the brachial plexus, so the C8T1 nerve root's becoming the lower trunk, when you get a pull on here, what happens? What gets compressed most? The lower trunk.
The lower trunk.
So you're going to see typically more involvement with ulnar nerve, but you can also get radial and median, but your ulnar nerve is going to be the most prominent for symptoms because of its orientation over the first rib. And we see women's first ribs are orientated more transversely, men more obliquely. So men have bigger spaces for the brachial plexus, where women have more of that transverse, so it's more of a hurdle. So you think about that tractioning. And we often thought historically about everything being a pinch or compression, but what we find with thoracic outlet, it's more of a tractioning or more of a pulling. So that's when I see ulnar nerve symptoms, like every cubital tunnel patient, the first place I go to is I look up and I test that out. And you know, I've had patients where within 8 seconds with an elbow flexion test, they have a positive test. But when I do the Roos test, it's elevated arm stress test, we're trying to talk about that instead of Roos, or something called the Cyriax release.
Cyriax release,
If that's within 5 seconds, I know more of the problem is here. I'm going to treat both, right? But I need to open things up here or nothing's going to happen downstream. I think it's particularly a problem more and more because what are we doing all the time? We're down with our phone, crunching forward. So I'm seeing more and more people at a younger age with nerve entrapment issues or compression syndrome, traction problems that shouldn't happen because we're all sitting like this. So, so the 2 tests that you can do in the clinic if you're suspicious of something going on at the thoracic outlet region, one is the classic test, the elevated arm stress test or Roos test. And you bring the arms up. Now, he described it within 3 minutes, but we can do it within 1 minute because they see a high rate of false positives if you do it for 3. So just coming up, you can add a little bit of depression on the scapula. So I'll come up and I'll put a little downward pressure on the scapula. I'll document that and I'll watch the clock. How many seconds before they get their symptoms? And where do they get their symptoms? You know, so does my patient say, oh, I'm starting to feel it right in through here. You're getting some median nerve symptoms after 5 seconds. I'll document that. And that's a nice way then to objectify those symptoms. So when I do my reassessment, hopefully in a month or 10 visits, not in 3 visits, but hopefully when I do that, the next time it'll be 25 seconds before they get their symptoms. So it shows objectively improvements because you're creating more space, alleviating that tractioning. So that's the first one. The second one is a little more unusual test. It's called the Cyriax release. So C-Y-R-I-A-X after James Cyriax. So we think about, again, we have this downward traction. Okay. So what happens if you're sitting on your foot and your foot's asleep? What happens when you take your foot out and you start moving around? You get blood flow. You get numbness and tingling, that icky feeling. So what happens with this is you have this downward tractioning. So if this is my first rib, you have this downward traction on your nerve all day long. You go to bed at night. The traction is released. It takes about 5 hours for the blood flow to return. What is going to happen with the patient? They're going to wake up with numbness and tingling. And when you hear that, so you're listening in your patient's history, they're going to wake up about the same time every night, and it's consistent. They'll say, I wake up, I shake my arm out, and I can't go back to sleep.
2 or 3 in the morning.
Right, exactly. So those are people then, so we're thinking, okay, people can be compressors. They can have their symptoms when they're overhead, or releasers where their symptoms are more at night. So these people, what we do to help test this is we unload their scapula. So you can either do it from their elbow or underneath the back of their scapula coming up. You unload them and you sit for a minute and see if that reproduces their symptoms.
Do you find one works better than the other?
As far as holding, like at the elbow versus the scapula?
So the pressure, you're lifting from here or you're lifting from here?
So I find it's easier because these people have big, heavy arms. I come in and I lift. I come up behind them and I lift from the scapula. That way I'm staying away from here because, again, a lot of them have ulnar nerve symptoms. You don't want to be by the cubital tunnel.
And do you find that women who are a little bigger breasted
Absolutely. Have more issues.
up from the scap like helps them like a lot more?
Absolutely.
Like they are big breasted and it does.
I have people, when I do that release maneuver, they're like, oh, that feels great. Can you walk around with me? My neck feels wonderful.
Just hold that boob up all day. Just, like, okay, I got you.
But what that does then, that release maneuver, is it's going to unload it and it's going to allow the blood flow to come back. Keep in mind the time of day is going to matter, though, because if you do it in the morning, they've already released, it's going to be negative. So the time of day you've got to document. So if it's 4 p.m., you document that and you do the release and you hold it for a minute, again, watching the clock. How long does it take before they get their symptoms? So two really simple tests that can give you a lot of information that, hey, I've got to look upstream. There's something else. And two, we think about 25% of all nerve cases distally have a proximal component. Opening things up here is going to make a world of difference with your results and your outcomes downstream.
Yeah, it's huge. Now that we've determined that, what's one thing that you could share with somebody who is watching this and says, I have somebody who has an ulnar nerve entrapment and I think it's here?
Yes. Okay. Well, two things. It's simple, but we need to start. We think everybody's like this. We need to start opening up the front. And the pecs are one thing, but don't be afraid to look down. Look at rectus abdominis, hip flexors. We need to open up the whole trunk. And I'm actually going to be doing a webinar on that for MedBridge on August 25th. It's called Maximizing Neural Mobility of the Upper Extremity. Good
I'm going to see if I can get your show on before then.
Awesome.
I've got a lineup, but I'm gonna shift people around first, okay, Ann?
Okay, that'd be great. That'd be great. So, so that's one thing. We need to open up from here. So the whole thing, remember, everyone learns in school to bring your shoulder blades down and back, down and back. Yeah. Well, what happens if you bring them down and back? Think about what's happening on the brachial plexus. Yeah. You're tractioning it. So we instead want to bring our shoulder blades up and back. So not down and back, but up and back. So I tell people, it's like if you're looking from behind, you're bringing your shoulder blades up and back. It's a diagonal coming up and back and then relax to hold. So you're unloading. So that's one piece. The second piece is getting the first rib moving. And I'm going to teach you how to find the first rib. So there was a study that Lloyd did in 2014 that looked at finding if you feel just behind your ear, that big bone is called the mastoid, mastoid process. They did a study that found if you take the mastoid process, you drop straight down, that is your first rib. You're going to land on your first rib. So coming, and I say tell patients from your earlobe, because basically it's the same as the mastoid. Come down from your earlobe.
What if they're attached and they're not? No big.
And you're going to be right on that first rib right here. Okay. Yes, perfect. So what you're going to do, we're going to do our own little first rib self-mobilization. So you're going to hold that with your opposite arm, and it's only about 1 centimeter. It's not very big. Yeah. You're going to take a deep breath. When you exhale, you're going to push that rib down. So basically going in this direction, pull it down and hold it.
It's not straight down. It's
angled. It's angled
towards your sternum.
Toward your elbow. That elbow you're pulling downward.
Okay.
Okay. Let's take a deep breath and exhale. Good. You're going to hold that 15 to 20 seconds. Maintain that, and you're going to take a second deep breath, but don't let that rib up. Keep it down. Take a second deep breath. When you exhale, you're going to push down a little bit further. So what that does, what happens normally, your rib comes up when you inhale, and it should drop down when you exhale. But when your scalenes work too hard, it pulls the rib up and keeps it up, so it's a bigger hurdle for your nerves. So by taking a deep breath, pushing it down, holding at 15 to 20 seconds, keeping that pressure, taking another deep breath and going a little further, what that's going to do is open things up.
It's kind of like a contract, relax type of.
Sort of, yeah. So you're starting, to let it drop. The thing you don't want to do, and I see these people do this all the time, is this stretch. This is horrible. You want to stabilize the rib and then stretch, because if you don't, those patients with elevated ribs are just going to lift their rib up more.
They're still going like that. Yeah.
So you can stretch. but you want to stabilize here, and not this type of thing is terrible if you have a brachial plexus issue because you're just adding more traction.
Yes.
So that traditional one that you hold the bottom of the chair and you come, I hate that because that's completely the opposite of what we want to do.
Right.
We want to bring the first rib down and bring the scapula up. We don't want to depress the scapula and elevate the rib.
Okay, so who would be good for that hold on the chair, pulling on the neck stretch?
That is an excellent question. I still have yet to figure that out. I don't know.
Somebody who doesn't have this problem.
Well, right. Someone who doesn't have an elevated rib, but it's still not great anyway for anybody.
Yeah.
But I don't know. That's a great question.
I don't do that stretch, but some people just love it. But, you know.
Yes. Well, I mean, momentarily it helps a little, but it doesn't. It actually causes your rib to elevate more, and so it causes more problems. So if you're going to do that stretch, I tell people you can do it, but stabilize the rib then, because your rib is going to want to pull up otherwise.
Like everything is, yeah.
Mm-hmm. What I tell people that you want your arm to move separately from your trunk. You don't want everything moving together, and that's what you see is people have posterior shoulder tightness. Everything's moving as a unit. That's not good. You know, we need to have, you want your arm to move separately. You want your scapula to stay up and back.
Yeah. I have somebody who I know who's going to watch this video over and over.
Good.
Right? 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 Couple people. Yes, I'm talking about them. They're like, you talking about me? I'm like, I'm talking about you, Willis.
So that's the biggest thing I think for, especially if you're newer to the hand therapy realm, just be aware. And the longer I practice, even though I am a PT, but still.
We love you anyway.
I hope so. I hope so. Because, you know, when people ask me what I do, I say I'm a hand therapist. I don't say I'm a PT, because when you become a CHT, you're in camaraderie. It doesn't matter what your discipline is. Like in our clinic, we have, I don't know, 15 OTs and 6 PTs, and you don't know who from who. I mean, everyone works together, and that's the way it should be, honestly.
Yeah. We are we're people who help other people with hand and arm problems.
Exactly. Right. I think once you graduate and you specialize, the degree that you started with doesn't matter anymore, honestly. I don't know.
Yeah. So it's funny because when I talk about who we help and I say very specifically occupational therapy, people are like, would you help physical therapists too? Absolutely. But the key thing is a marketing message. When you're saying stuff, you don't want to list out all the people, like using like, do you help OT assistants too? Absolutely. You fall under the realm of OT, you know. Like we help you. If you want to specialize, we can help you. Right. It really comes down to you know, we are just people who help other people.
Right.
And so tell everybody where they can find you. Like, how do people get in contact? Because I know a lot of people are going to love this video, and you like so much information with us already. How can people find you, and how can people take your classes?
So I sent you some of those links too, but so
I'm going to include them under the description.
Awesome. So I teach live courses for the company called the International Academy of Orthopedic Medicine, IAOM, and we have just a hand and upper extremity track specialty track of courses. We have 6 courses. We have 1 in the hand, 2 on the wrist. Like the 1 is just on wrist instability and understanding the mechanics and understanding that course since it was put together back in 2010 has changed the most, because the research out here is so amazing with the proprioceptive training and all the things with dart throwers. I mean, it's just been so exciting.
That has dominated the chapters in the reading of the handbook. I know, I don't even have to go back to those red books or the yellow books. I know that has changed the most.
Yeah. Since Elizabeth Haggart came out in 2010 with her first proprioception, and then all the work of Elias Garcia, and just amazing. And that's what's fun, is like things are always changing. So what we maybe do today is not what we're going to do in 2 years based on the research. So that whole course has changed the most, because our understanding of how to treat conservative wrist instability cases has drastically changed for the better. We have a lot more tools. But we have a course on the elbow, we have one on the shoulder, and one just on thoracic outlet. And they're 2-day courses.
Yeah.
And the nice thing is they were created by CHTs, and the majority of people taking them are hand therapists or CHTs that are like in process. They're studying for the CHT.
They're
and it's
studying
really
for it,
cool.
yeah.
It's fun to all get together. People from all parts of the country get together and learn together. It's great. It's great.
I love, there's a place for both. I feel like there's a place for online learning and there's a place for live learning. And it's a matter of, you know, I just always that search to keep going and keep looking for, continuing to learn. So you've got the live stuff, and tell us a little bit about your online stuff.
So I have, I think 11 courses.
Wait, you froze a little bit.
Oh, okay. So,
start over.
Okay. So I have some some webinars on MedBridge. So MedBridge Education is just an amazing platform. They have all sorts of different things, but for therapists, they have like a huge library of continuing education courses, hundreds of courses, and you pay for a subscription, but then you have access to everything, which is really cool. So I have 11 courses on hand and upper extremity rehab using that systematic approach, that Syriax-based approach, 4 courses on thoracic outlet, several on lateral elbow pain, because lateral elbow pain is one of those things that people love to treat, right? Or
well, you know why I love to treat it? It's because, one, I have it. I had it. And 2, it's unfortunate that a lot of people can leave it going so long.
Right. It can be very chronic.
They brace for it, they inject for it, they take pills for it, and they lose hope that anything can be done to actually get rid of their problem. So it's a hard thing to treat because it's one of those things, anything that's like comes and goes, and people can ignore it, that's hard to treat. And so that's why, you know, like I've written a book about how to treat without, you know, like for the consumer, for the person having the kind of pain. Because as a therapist, you know, we do fall in like, oh, let's do it based on you doing your home program and stuff like that. But everyone who comes into us come in a different way. Sometimes they come into us and they want us to do everything. Why should we assume that they're going to want to do everything on their own, right? And then some people, they just want to come a couple of times and they're like, I got this, I'm going to do it on my own. Because they're motivated. They you know,
they have the tools. You gave them the tools, what they need.
Yeah, I just want the tools. And then some people, they want to just keep coming. But there's a lot of people who've tried different things and then give up hope because they didn't get it fixed the first time. And so they're like, well, it's just something I have to live with, or it's just because I'm old, you know. But it's very possible, you know, to get rid of that type of problem. And I think it's great that therapists can access your type of classes to really teach them how to get rid of it for good.
Right. Because there's a lot of things you find out underlying. There's more joint issues and chondropathy problems. And that makes a lot more sense why you can see the chronicity of this problem. So, it's great. Yeah. So the MedBridge things are nice because they're all recorded. They have demos too. You can play and replay as much as you like, which is really fun. And you can play it on your phone. You can do, you know, whatever. I take MedBridge courses when I'm like on the elliptic trainer working out. It's like, it's fun, you know? You have little questions that you have to answer and it makes you think. So it's great. Yeah. So
cool. So people can access you live, they can access you online. So I'm going to include all those links below so that you guys can find Anne and all the great work that she's doing, because she's going to read all the articles for you, all the research, and she's going to make it real simple.
Right. Because I know we don't have time to like pour through all. My husband's very patient. I have a stack of articles always on the kitchen table, but he's great.
Yeah, he's great. I don't have the patience to go through all that research. So I myself take tons of classes, but I take I take business classes now, you know, running my own clinic and stuff like that. But I take, you know, skills classes and, you know, research. I thought research was going to be my thing. I thought research was going to be my thing. And I was going to, you know, teach academically and do research. And then I found out like, dang, this is not Like,
I really like being in the clinic. I like this reading of studies and how it's applicable in the clinic because I'm a clinician. You know, I'm in the trenches.
yeah.
I see patients. That's what
Yeah.
drives me.
Well,
That's what I like.
thank goodness for all of us being just slightly different,
Right.
so that we can add to the world of hand therapy. Like,
Absolutely. Absolutely. Well, thanks for having me. This was really fun.
no, thank you. Thank you so much. All right. So I'll include all that so people can find you. All right.
Okay. Awesome.
Appreciate all your time today.
Yeah.
So much.
You're welcome. Thanks. And good luck with everything with you're amazing. All the stuff you do. I'm like, wow, that's so cool.
I don't know. I think you do an amazing, a lot of stuff and amazing too. So
You get it out there though. That's good.
I'm going to get it out there, and I'll probably have you on again at some point.
That sounds good. Yeah, actually, I'd be happy to do it. So whenever you want another one, let me know. Okay? Awesome. Okay, thanks.
Bye.
All right, take care. Have a good rest of your week.